second speaker is Dr. Tiffany Yao. Dr. Yao is an endocrinologist and is an associate consultant from the Prince of Wales Hospital at the Department of Medicine and Therapeutics. She is the physician in charge of the clinical and administrative management of patients with gender dysphoria in the Prince of Wales Hospital since 2017. She has experience of overseas training at the Nottingham Centre for Transgender Health Charing Cross Gender Identity Clinic in May 2017. Her special interest is also in diabetic technology. May we invite Dr. Yao, please?
Thank you, Dr. Chan, for the kind introduction. I'm Tiffany from the Prince of Wales Hospital Endocrine Division. So in the next 20 minutes, I'll try to cover as much as I could about how we assess a transgender person before we initiate hormonal treatment, what options do we have, and how do we monitor them, and what are the risks that is associated with treatment. So what is our role in the transgender care? So after psychiatrist has established a diagnosis of a transgender, they would refer the clients to us to start assessment for starting hormones. And whether the clients request for sex reassignment surgery or not, we would need to provide continuous care for these people. So what is the role of gender affirming hormonal treatment? It is to enhance the psychological well-being in the desired gender and to optimize the feminization and masculinization characteristics, as well as to minimize the existing secondary sexual characteristics. And of the principle of treatment is to suppress the endogenous sex hormone, as well as to introduce the cross-gender hormone. So put it very simple, for trans men, we're aiming the testosterone and estradiol level in the normal male range, and for trans women, vice versa. The treatment for transgender people has to be individualized because it depends on different patients' goals. Not all patients are aiming for full masculinization or feminization. So we do have some clients that actually does not feel they need hormones at all because they're satisfied with their physical appearance. So we need to assess what are the goals. So we also need to balance the risk and benefit of medications, the presence of other comorbidities that would affect our choice of treatment, and also a consideration of social and economic issues. For example, what medications are available in the public and what medications that the client may have to self-pay. And also different treatment medications are available in different localities. Okay, so what are the criteria for hormonal therapy? This is from different guidelines. So you first need to have a well documentation of persistent gender dysphoria, and the client has to have a capacity to make a fully informed decision and to consent for treatment. And in certain countries, for example, in Hong Kong, they have to be at least about from age of majority. And if there are significant medical or mental health concerns are present, they must be reasonably well controlled. So in our center, when we first assess a client for hormonal treatment, we will go through first the history, including the birth, developmental, and pubertal history. And for trans men, we will also ask about their previous menstrual history. And we need to know their smoking and drinking status, and as well as personal and family history, especially talking about cardiovascular risk factors, for example, hypertension, diabetes, dyslipidemia, and any presence of cardiovascular or cerebral vascular disease, and whether they have any history of venous thromboembolism, liver disease, and breast and gynecological cancers. So we will check the blood pressure and body weight, and for some clients that we have suspicion in the history, then we will also perform a breast and genital exam. And as for a baseline blood test, it includes some complete blood picture, liver and renal function, the sex hormones and related hormones, the lipid and glucose profile. And we used to do chromosome analysis years in the past, but nowadays we don't feel that it's necessary anymore. So first talk about the hormonal treatment for transgender men. And this is a table summarizing the different testosterone preparations that is commonly used for treatment worldwide. And it basically includes either injections, for example, subcutaneous or intramuscular injections, or dermal preparations, for example, gels and patches. So it depends on different localities which drug is available. In Hong Kong, the most commonly used drugs that we prescribe is those I highlighted in red, the testosterone propionate, and as well as the testosterone andecanoate. So When we start hormones, we will gradually start to see some body changes. Some changes might come on more rapidly, for example, within 2 to 3 months, but some changes may come on later, and some may actually take maybe 2 to 3 years to see a full effect. So this is a nice figure summarized from the Lancet Diabetes and Endocrinology, showing that after all the changes that you see after starting treatment. So if we look at the left, after starting treatment, you'll see an increase in facial and body hair. You'll see a reduction in breast size, cessation of menses, and some clients actually have the menses stopped even after the first injection. And there will be an increase in clitoral size. And on the right, they might experience quite severe acne, especially in the first year. And the voice will start to deepen down. They will have increase in muscle mass, especially if they do some exercise for muscle training as well, and the reduction in the fat mass. So we talked about the aim of the treatment is to have the testosterone estradiol level in the normal male range. However, we have to take note that if the transgender men are started on, for example, dermal preparations, the testosterone level is usually more stable. However, if the client is put on injectables, for example, 1 to 2 weekly injections or 4 weekly Sustanon injection, they actually have a fluctuating level instead of a steady level. So they will have peaks and troughs. So what are we monitoring? We're looking either at the pre-dose or the mid-dose testosterone level. And what is the general aim of the testosterone level? So there are no hard and fast fixed numbers. Basically, we want to keep the mid-dose level or the general testosterone level within the male physiological range. And that is somewhere around 10 to 34 nanomole per liter. So before starting treatment, we have to make sure that the client does not have contraindications for androgens. And the common contraindications includes pregnancy or a wish for active pregnancy, unstable coronary artery disease, and untreated polycythemia. And the reason for that is androgens does have some risk. And these also applies to, for example, other patients, for example, male hypogonadism on testosterone. So there are risks of erythrocytosis, that is a rise in the hemoglobin and the hematocrit level. There's a risk of atherogenic type of dyslipidemia, that is a low HDL, a raised triglyceride, and a raised LDL. The blood pressure might rise a bit, but it's usually not very significant. We used to have concerns whether androgens testosterone would cause severe liver dysfunction. But nowadays, we know that in the transgender population, severe liver dysfunction only occurs if oral testosterone is used. So intramuscular injections or dermal preparations are usually quite safe. And there is also a risk of coronary artery disease or cerebrovascular disease. So how do we monitor these clients after starting hormonal treatment? We need to monitor the blood test, and that includes, we mentioned testosterone level, estradiol level, basic parameters, and also the lipid and glucose profile. We would check the blood pressure and body weight each visit, and for those whom has not had a hysterectomy done, we would suggest them to have a regular gynecological exam, which is similar to a cisgender female, and that includes pap smear and HPV testing, etc. But usually for transgender men, they will feel rather uncomfortable and may be quite distressing for gynecological exam, and therefore we have to discuss with them and see their own choice. So there has been concern whether transgender hormones or testosterone will have an effect on bone health, cancer risks, or cerebrovascular, cardiovascular risks, etc. So till now, there are no very strong evidence, but generally they found that there is no obvious increased risk of osteoporosis. And therefore, they suggest that osteoporosis screening is suggested only in those whom have stopped testosterone treatment, they're non-compliant to hormones, or they have other risk factors for bone loss. So in one study, they have noted that serum LH levels were inversely related to the bone mineral density, suggesting that low levels of sex hormones were associated with bone loss. And therefore, some people have advocated that checking LH levels and making sure that it's not normal range may serve as an indicator for the adequacy of sex hormone administration to preserve the bone mass. As for cancer risk, till now there are no data to support increased risk of breast or endometrial cancer, but these data are limited to case reports only. And as for cardiovascular risk, there is also no evidence for an increase in short-term and mid-term cardiovascular adverse outcomes in trans people on testosterone treatment. So basically, we suggest to manage transgender persons' cardiovascular risk factors just similar to the local, to the population, general population guidelines. So we'll also move on to talk about transgender women. And for transgender women, apart from initiating estrogen, we would also suggest to add an anti-androgen. And the reason for that is estrogen itself would also lower the testosterone level through a negative feedback on the pituitary gonadal axis. However, estrogen is associated with an increased risk of venous thromboembolism. And therefore, we would suggest a concomitant androgen lowering agent so that we can use less doses of estrogen. So these are again a table summarizing the common estrogen and anti-androgen preparations that people use in different localities. So for estrogen, it's basically depend on different administration routes, oral tablets, intramuscular injections, or transdermal preparations. And a point to note for oral estrogens, the most favored estrogen is the 17-beta estradiol because that is shown to have the lowest venous thromboembolic risk, whereas conjugated estrogen are less preferred, and ethinyl estradiol are not recommended because of a higher VTE risk. And as for anti-androgen, there are choices including spironolactone, cypertran acetate, and GnRH agonists. Spironolactone, some of you might have heard of, is actually a drug, for example, to treat hypertension, to treat heart failure, etc. But it actually carries an anti-androgenic property and therefore is used for transgender treatment as an anti-androgen. Cypertran acetate is also a similar drug that contains anti-androgenic properties. So I just mentioned that ethinyl estradiol are rarely used and is not recommended because of a higher VTE risk. And many clients may come asking you for progesterone because many people believe that progesterone can promote breast growth and have a better improvement in the breast size. But however, studies have still shown that the effect on breast growth is still controversial. And we have to note that in other studies looking at cisgender postmenopausal women, progesterone can increase the risk of breast cancer, heart attack, stroke, and also VTE. And therefore, we generally do not recommend and we do not prescribe progesterone for our clients. So the aim of treatment, again, is to keep the testosterone estradiol level in the normal cisgender female range. But one point to note that for a cisgender woman, the estrogen level shaded in blue actually varies depending on the cycle, the menstrual cycle that the woman is in. So we can't aim for a level similar to a cisgender woman. And basically, we're aiming blood levels for the estradiol level to be between 100 to 200 picogram per milliliter. And in our unit, we use picomole per liter, so that's roughly around 300 to 700. And again, we have to take note for those on intramuscular preparations, the level is more fluctuating and therefore is more difficult to monitor. As for anti-androgen, we're aiming for a testosterone level less than 50 nanogram per deciliter, or in our center, around less than 2 nanomoles per liter. So again, this is from the Lancet Diabetes and Endocrinology, summarizing the body changes that you'll see after starting hormonal treatment. So you will see an increase in breast size, but usually the increase in breast size is usually not up to the client's satisfaction in most of the cases. So some clients might go for augmentation, mammoplasty, etc. The skin will soften and you'll see less acne. There was suppression of penile erections. and there was a reduction in the muscle mass and an increase in fat mass, and reduction in facial and body hair. But one point to note, for transgender women, estrogen and anti-androgen would not bring a significant effect on the voice. And therefore, for some clients, they might need to refer to the speech therapist for voice training. So there are known contraindications for estrogen. In the transgender population, I'd say it's a relative contraindication that includes a prior history of venous thromboembolism, a strong family history of breast cancer, cardiovascular or cerebrovascular diseases, severe liver diseases, and severe migraine headaches. Because we know that estrogens are associated with a risk of thromboembolic disease, and this is dose dependent. And oral estrogens are probably more thrombogenic because of the liver first pass effect than as compared to transdermal and peritoneal routes. And therefore, transdermal estrogen might be preferred in those older than 40-year-old with a high risk of thromboembolism, cardiovascular risk factors, or complications. And so there is also a concern on hyperprolactinemia or macroprolactinomas. And that's because trans women treated with estrogens might have elevations in prolactin levels, which is associated with enlargement of the pituitary gland. However, till now, there's no very strong data, and some believe that the prolactinoma risk is actually very rare, of less than 0.1%. And therefore, for a mild degree of hyperprolactinemia, it's not necessary to reduce or stop the estrogen therapy. And as for hypertriglyceridemia, it's actually a well-known kind of side effects of estrogens, similar to other women on, for example, OC pills or HRT. So again, for monitoring, basic blood tests similar to trans men, and we'll also monitor prolactin every 1 to 2 yearly. And also, similar to trans men, there has also been concern whether trans women hormonal treatment has an effect on bone health, cancer, or cardiovascular risk. So for bone health, there hasn't been data to show that there's an increase in osteoporotic risk. And therefore, osteoporosis screening in low-risk cases should be conducted at more than 60-year-old or those that are non-compliant to hormones. And there are also no data to show an increased incidence of cancer in trans women treated with hormonal therapy. And there is concerns on cardiovascular risk, however, because there is the largest available cohort study showing that trans women on estrogens has a higher risk of VTE, higher rate but to a lesser extent of ischemic stroke as compared to cisgender men and women, and a higher rate of myocardial infarction as compared with cisgender women, but similar to those observed among cisgender men. However, we have to note that the evidence till now is still of a low quality due to methodological limitations and also heterogeneity of treatment. So we can only conclude that further research is still needed to better clarify the risk. So this is my final slide. It's very important to discuss with our clients in terms of fertility before we start treatment, especially before sex reassignment surgery, because we do have a few clients in our clinic that might still have fertility wish in the future. So we should offer options of cryopreservation for these clients if they have a possible future fertility wish. But we also have to discuss with our client that it depends on the laws in different countries in terms of marriage laws, in terms of laws that governs, for example, assisted reproductive technology. Because even if the clients in our locality had cryopreservation done, according to the current law, they might not be valid for in vitro fertilization or assisted reproductive technology. So thank you very much for your attention, and we welcome any questions and try to answer them towards the end. And I'm sorry for a bit of technical interruption.